Good morning, everyone. Welcome to TeleShadowing. We are live streaming this session to YouTube. Please feel free to ask questions in the chat box as we go along and they will be addressed. I'm honored to introduce our mentor for today, Dr. Kashif. Dr. Kashif is a member and fellow of the College of Physicians and Surgeons and serves as a physician specialist registrar of obstetrics and gynecology at Oxford University. She's also a member of the Royal College of Obstetrics and Gynecology. Now I'd like to request Dr. Kashif to begin today's session. Thank you.
Hi everyone, welcome to today's session. So I'll introduce myself quickly as well. We will have a quick chat about the practice of the UK. Okay. So, I did my graduation from Pakistan, Rawalpindi Medical College, and I did a year of training after graduation. And then I entered into the proper training program, which is for 4 years, training started. Hello, everyone. I'm really sorry. My connection got lost. So I hope you can hear me now.
Yes, we can hear you.
Okay, thank you very much. Okay, so I'll introduce myself first of all. Thank you so much for your introduction, Amina. So I graduated from the Rawalpindi Medical College in Pakistan, and then I did my fellowship, which was after 4 years of training program in Pakistan, and that was in obstetrics and gynecology. Then I worked there for a few years. Then I had my membership from the Royal College of Obstetrics and Gynecology, UK. And then basically that's a way of, that's another way of coming to the UK basically. So I will discuss the pathways to the UK when we will start a proper presentation. But that's one way of getting yourself registered with the General Medical Council UK. And then I came here, and I've been working in the Oxford University hospitals for the last more than 2 years, actually. So I'll show you a few slides that will actually clarify how people can actually come to the UK. So there are different pathways, basically. One is PLAB, and the other is, can you guys see my screen?
No, we don't see your screen.
Okay. I can see here host disabled participant screen sharing.
Yes, let me fix
Can it be enabled, please?
Yes.
Okay. So there are different pathways to come to the UK, basically. One is PLAB and the other is a membership exam. So because you have to get yourself registered with the General Medical Council before coming to the UK, and these are the two ways to get yourself registered. So after medical school, you need to have 2 years of foundation year training here, and then 3 years of core training, and then 3 to 4 years of specialty training, basically. And then you can work as a consultant in the UK. So simply, this is the route. But then people go through either the membership route or the PLAB route. So basically, as I said, that you have to apply for the GMC registration before working here, like any other country. So after med school, if people are working somewhere else, like India, Pakistan, anywhere else, they have to take the English proficiency test. There are 2 types of tests. One is IELTS, and the other one is OET. IELTS is basically like a general English test, and that's the you have to take the academic IELTS, and OET is more medical. So it's a little easier than IELTS for medical professionals. So after you take the English proficiency test, then is PLAB 1, and then it's PLAB 2, which is a practical exam. And then you apply for the GMC registration, and then you can work in the UK after you have your ID checks with the GMC. And then obviously, whenever you get a job offer, you can just join in. Okay, so basically that is it. But there is another route through which I came to the UK. That's a membership. So if you take the English proficiency test and you are done with your membership, then you can skip this bit, and then you can get yourself registered with the GMC, and then you can start working in the UK. Then once you start working in the UK, to become a consultant here, there are again 2 routes basically. Either it's a CCT, which is a certificate of completion of training, if you go through the training program, and then is basically CCT and CSER. We'll just skip this bit for now, just to avoid any confusion. So if you go through the training program, it's CCT. If you do not go through the training program, but you can provide an evidence of competencies to the GMC, then you can become a consultant through the CSER route. Okay, yeah, so basically that's it. And then, as I said, that people either take the PLAB route, which is the basic exam, basic medical exam, or they can do specialty training in their home country and then come here after taking the membership exam in the UK. So that's the second route. So if I'll go back a little bit. So when you come to the UK after doing your membership exam, then you can skip this bit of the foundation years and maybe join here. Specialty, you can join as a specialty registrar. So these 3 or 5 years you can skip, and then you can work directly as a specialty registrar in one of the NHS trusts. And then you can go ahead with the CSER route, or you can also apply for the training. It depends upon your own interest. Okay, so towards the end, we can have a detailed chat about these things if anyone has any questions regarding that. Okay, so basically what I wanted to discuss today is, I think I have lost one of my slides, but anyways, I would like to have a discussion about a postpartum hemorrhage, because that's a very, very important obstetric emergency. And even as a new graduate and working in your foundation year or during your house job, if you're working in the emergency department or in the obstetrics and gynecology, you may encounter women with postpartum hemorrhage, and that's a very important aspect of obstetrics. And so I just thought that we can have a discussion about this today. So postpartum hemorrhage is, as I said, that it's a very important obstetric emergency, because it's a very, very important cause of maternal death. So if you go online, you can read many stories about women who went through postpartum hemorrhage, and it was a horrendous experience, and they were extremely traumatized by that experience. And this is one such story. And this lady, basically US based, and I think she delivered in 2017. She shares her story that she went through a very normal pregnancy and very uneventful delivery, and she thought that was just just a very smooth experience for her, very happy. Baby well, mom well after delivery. And then she had secondary PPH. So we will discuss the causes and the definitions of the postpartum hemorrhage. And then we will see what a secondary PPH is. Basically, it's when it is more than 24 hours after delivery. So it was on day 5, and then she bled heavily. She that was a horrendous situation for her. And then she went through a very difficult time. But thankfully she was saved, and she shares her experience, and now she's working to educate other moms about postpartum hemorrhage. So that's a good thing that she went through a difficult experience, but she took it positively to educate other people. But this is just to highlight the importance of postpartum hemorrhage, that in addition to being a medical emergency, it can leave a woman very traumatized. So if we look at the causes of maternal mortality, even in the well-developed countries, so we can see that obstetric hemorrhage is still a very important cause of maternal mortality. As in US, we can see that 7.8% of the women died because of the obstetric hemorrhage in between 2007 to 2016. It's quite a wide range, but anyways, this percentage is quite significant. It doesn't say whether it was only postpartum hemorrhage or also bleeding during a pregnancy for other reasons, but hemorrhage is a very important cause of maternal death. So as clinicians, we should be well versed with the risk factors, how to manage it, and how to prevent it, and aftercare of the women who undergo such a difficult situation. And this is from the UK, which is the recent report. Here, the report is called Embrace. And if we look at the causes, are you seeing this a little bar on my slide as well, or it's the whole of the slide is visible as such?
The whole slide is visible. That's just
okay. That's fine. All right. Yeah. So if we look here, so there are different causes of maternal mortality, as you can see here, but still the bleeding is very important cause. And 8% of the women still in 2019, they died of bleeding related to pregnancy. So that highlights the importance of postpartum hemorrhage or bleeding in pregnancy. We will focus today on postpartum hemorrhage, basically, but there are other causes of bleeding in pregnancy as well, such as miscarriage, ectopic pregnancy, bleeding during pregnancy, which is called antepartum hemorrhage. Then there are different causes for that, such as abruption and placenta previa, placenta accreta, but we will focus today on the postpartum hemorrhage. Okay, so with regards to the formal definition, postpartum hemorrhage is either primary or secondary. As I said, that secondary postpartum hemorrhage is when it occurs between after 24 hours. So primary postpartum hemorrhage is blood loss of 500 mils or more from the genital tract within 24 hours of the birth of the baby. It can be minor. Then there are different categories such as minor, major, or severe. So minor, 500 to 1000 mils, major, more than 1000 mils. And then the major can also be divided into moderate, like 1000 to 2000 mils, or severe, more than 2000 mils. If we don't even remember all these numbers, the importance is to, the thing that is important is to control the hemorrhage at this level. When it's a minor hemorrhage, we should be able to recognize it, and we should be able to treat it here so that it doesn't go till this stage. And then the secondary postpartum hemorrhage is defined as abnormal or excessive bleeding from the birth canal between 24 hours and 12 weeks postnatal. So quite a wide range. And the causes of the secondary postpartum hemorrhage are very different from the primary postpartum hemorrhage. And when we will discuss the causes, we will have a chat about that as well. So coming to the causes of the postpartum hemorrhage, if just to simplify, there are 4 major causes, which we can, if we remember the mnemonic of 4 T's. So it could be thrombin, tissue, tone, and trauma. And there are certain other causes as well, which are basically the risk factors. So we will discuss them briefly as well. But looking at the causes which are related to the clotting, basically, preeclampsia, which can lead to clotting disorders such as low platelets, and then placental abruption, which can also lead to massive hemorrhage, and then DIC, and pyrexia in labor or sepsis, bleeding disorders which are pre-existing, such as hemophilia, anticoagulation, due to sometimes because of the risk factors of thrombosis, women are prescribed anticoagulants, and if they are already taking anticoagulants, it can lead to heavy bleeding. And then von Willebrand's disease. So there are different causes of different bleeding disorders which are pre-existing, and that put women at risk of having bleeding at the time of delivery. And then retained, if we look at the tissue, which is the pregnancy tissue, which is retained inside, then it's the retained placenta, placenta accreta, and retained products of conception. So sometimes after delivery, the placenta doesn't follow the birth of the child, and then it could be retained, and that can also lead to obstetric hemorrhage. And then it's placenta accreta, which is a placenta which is abnormally adherent to the wall of the uterus. And then retained products of conception. For example, a woman is delivered and she goes home, a placenta is out as well, but a little bit of the placental tissue or some membranes are still inside, then it can lead to retained products of conception, which can be a cause of the secondary postpartum hemorrhage, or sometimes primary postpartum hemorrhage as well. And then is the tone of the uterus. As soon as the baby is delivered, the uterus should ideally, after the delivery of the placenta, it should contract. And if the uterus doesn't contract properly due to different reasons, for example, placenta previa, which is a placenta which is implanted in the lower part of the uterus, and because the lower part of the uterus is less muscular and it has less ability to squeeze the blood vessels, so it can lead to more bleeding at the time of delivery. Then over distension of the uterus with multiple pregnancy, polyhydramnios, and macrosomia. When an enlarged uterus, that takes more time to come back to the contracted state after the delivery of the fetus. And then uterine relaxant. Sometimes women are taking the medicines, or we give them medicines during labor, which can lead to a relaxed uterus. And previous history of postpartum hemorrhage is also an important cause. So women who have a history of postpartum hemorrhage in their previous pregnancies, they are at risk of having postpartum hemorrhage during their deliveries later on as well. And then it could also be related to trauma such as cesarean section. We expect women to bleed more at the time of cesarean section because of the surgery from the surgical wound, and also episiotomy, which is an incision which is given at the time of delivery in the perineum, and also if they have any tears. And then macrosomia, if, for example, if the baby is big, sometimes the delivery can be traumatic. It can lead to more tearing and also shoulder dystocia, and then it could also be a cause of bleeding. And then there are certain risk factors such as Asian ethnicity, anemia. So women should have regular blood tests in pregnancy, and we should make sure that their hemoglobin is optimized during pregnancy, because that's also a risk factor for a postpartum hemorrhage. And then induction of labor, use of oxytocin, instrumental delivery. So these are all the risk factors for having a postpartum hemorrhage. So then if we look at what are the reasons that could lead to death, basically delay in diagnosis and underestimating the blood loss, delay in transfer. If a unit doesn't have proper facilities to resuscitate and treat the women, because in postpartum hemorrhage, women can sometimes bleed very quickly. And if we do not control that hemorrhage, or we do not start proper treatment and resuscitation at an appropriate time, then it can lead to maternal death and delay in management, as I said. And then basically, since it's a very important cause of maternal mortality. So it's very important to identify and treat and then transfer appropriately in order to avoid mortality. Postpartum hemorrhage is very often underestimated, and it's very easy to miss. So if we look at these swabs, which are used during the time of delivery, then we can see that, you know, this very mildly soaked swab that still holds 5 5 milliliters of blood. And if it is fully soaked, then it's 30 mils. And just imagine that if there are a few clots on that as well, so it's actually even more than that. So it's very important to make sure that we are estimating the blood loss properly, so that we can treat the woman properly as well. Because if she loses a lot of blood quickly, then she may go to DIC, and then it can also lead to renal injury. So sometimes these things can also lead to an irreversible damage to a woman's health. So it's very important to identify and to quantify and treat a postpartum hemorrhage. And these are the under buttocks drapes, which we normally use for a vaginal delivery. And it's basically a very good way of measuring a blood loss. As we can see that when this drape goes under the patient's body, and this is the basically a pouch which is hanging down, and it has got these markings, which is a very good way of measuring the blood loss. So these can be used and are quite helpful. So in order to quantify the postpartum hemorrhage, an easy formula is that 1 gram is equal to 1 milliliter, as we know that. And also another important thing, as we can see here, the total blood volume at term is approximately 100 mils per kilogram. So an average woman of 70 kilogram weight, she has got a total blood volume of 7,000 mils. And a blood loss of more than 40% of the total blood volume is generally regarded as a life-threatening loss. So which means that if this woman of 70 kilograms, she loses 2,800 mils, it could be life-threatening for her. And this threshold should change based on the BMI of the women. So the women who have a low BMI or who have a low weight, for example, this will not be the same for a woman who is 47 kilograms or 50 kilograms in weight. And so the threshold of PPH, for example, if we say that the PPH for a woman is, by definition, it's 500 mils, then we should be more vigilant in managing the women who have a low BMI. For example, if a woman who has got a weight of 50 kilograms, then our threshold should be lower than that. It shouldn't be like 500. I would be worried if she loses like 400 or maybe 350 milliliters, and it's an ongoing loss. So we should individualize this as well. So we should remember that every woman is at risk of developing postpartum hemorrhage, and active management of postpartum hemorrhage prevents postpartum hemorrhage in 60% of the cases. So many women in labor, we can, for most of the women, we can identify certain risk factors, such as previous history of postpartum hemorrhage. They are anemic, they are carrying a big baby, then twin pregnancies and things like that. But for many women, there are no risk factors, but still they can bleed heavily. So we should always be mindful of the fact that any woman can bleed heavily during labor. And ideally, women should be offered active management of third stage of labor. We will discuss that in a few minutes. So prevention of PPH in third stage is very important. And after the delivery of the baby, before the delivery of the placenta, that's the third stage of labor. So if the woman can be, after discussion with the woman, of course, if they agree to have the third stage of labor to be managed actively, then we can give them either an oxytocin injection or a combination of oxytocin and ergometrin, which is called symptometrin. That helps in reducing the amount of blood loss significantly, and also helps in reducing the chances of them having blood transfusion very significantly. So that's a very useful way of managing the the third stage of labor. But some women prefer to have physiological third stage, that is, they don't want any intervention. So that can lead to heavier blood loss and may increase their risk of having blood transfusion as well. So it's almost the same thing. So how can we manage basically the third stage of labor appropriately? So as we discussed already, that in most cases, no identifiable risk factors are there. Active management lowers maternal blood loss, reduces the risk of PPH, risk of having blood transfusion, Oxytocin is basically the management ideal drug to be used. And as these are basically the things that we have discussed before, that it reduces the risk of PPH by about 60%. And in vaginal deliveries, basically different regimes are followed. In vaginal delivery, oxytocin 5 units or 10 units by intramuscular injection, because some women who are low risk, they may not have an IV cannula in, so they can even have this intramuscular injection. And at cesarean section, the recommended management by the Royal College, these are basically the recommendations by the Royal College of Obstetricians and Gynecologists. That is at cesarean section, 5 units by slow intravenous injection. So this is basically quite helpful. Then another option is symptometrin, which is a combination of oxytocin and syntocinon 5 units, or oxytocin and ergometrin, and that may also be used. But we have to be mindful of the fact that ergometrin can increase the woman's blood pressure, so it should be used in the absence of hypertension. For example, if the woman has got antenatal anemia, that can reduce the risk of a minor PPH, but we can have a discussion with the women that sometimes it also leads to some nausea and vomiting. And if it's a lot, then we can also prescribe them some anti-sickness medication if they want. So this is basically one side effect, but otherwise it's quite helpful. Misoprostol is a prostaglandin, and it's also a recommended management. And there are certain benefits of using misoprostol over other medication, because studies say that it is not as effective when compared to oxytocin. And it also carries the dose-related side effects such as pyrexia, diarrhea, vomiting. But in certain situations, for example, in remote settings, particularly when there is no oxytocin available, or the birth attendants who are the traditional birth attendants or women in remote area, they can be benefited using misoprostol, because we don't need any special conditions, any refrigeration for this medicine. So even at home birth, women can have that, and it significantly reduces the risk of hemorrhage. And with regards to the mode of administration of misoprostol, it's available in tablet form, so they can have sublingual or perrectal. Pervaginal is not suitable after delivery because of bleeding, and it's less effective when a woman is bleeding as well. So there are different routes of administration and different dose recommendations as well. Some people use 600 micrograms, some use 800 micrograms, some use 1000 micrograms. One tablet is 200 micrograms. So based on different people's experience and different studies, people have got different regimes of misoprostol that they find effective. So this is an extract from the British National Formulary, that is 5 units by slow intravenous injection, as we have seen in case of cesarean section. We can then start the woman on an intravenous infusion of oxytocin, which is 40 units in 500 mils of normal saline, and then it's ergometrin, and then basically the same things that we have discussed previously, or symptometrin. Okay. So oxytocin infusion is a continuous infusion after giving the women, if for example, if we give a woman the active management of third stage of labor, as we have discussed, oxytocin injection, intramuscular at the time of vaginal delivery, intravenous at the time of cesarean delivery, and still there is an ongoing bleeding, then the next step will be oxytocin infusion, and then oxytocin infusion has got a short half-life, and which is 3 minutes, sorry, and maximum dose, as we have seen in the BNF, is 40 units. And then it's ergometrin. Onset of action, as we discussed, is it's also quite quick, and the onset of action is 2 to 5 minutes, and its effect lasts till 3 hours, and hypertension is a contraindication, as we discussed. Then the next step is Some people use misoprostol, but the recommended management by the Royal College of Obstetrics and Gynecologists is carboprost, which is also a prostaglandin, but it shouldn't be given to the women with asthma. Then for carboprost, we can give intramuscular injections or even intrauterine or intramyometrial injections, especially at the time of cesarean section. And it's quite effective, and the doses can be repeated at an interval of 15 minutes. And we've discussed these basically the benefits of misoprostol, that it's stable at room temperature, various routes can be used, and it's quite cheap as well, and can be used in different birth settings, for example, home births and midwifery-led units, and even by the traditional birth attendants or the people who are not very trained to administer medicines. They can also use misoprostol. So that's very useful. Tranexamic acid has been found to be very effective, and recently there have been a few trials to check the efficacy of tranexamic acid in the postpartum hemorrhage. So it has been found, there was an article from Lancet, basically, 39% of the reduction in the blood loss was found in case of trauma, and also a significant reduction in postpartum hemorrhage. So that's the next step. That is, if the woman is continuously bleeding in spite of the uterotonics initially that you have given, for example, if you have given the active management of third stage of labor, the bolus of oxytocin, and then you've started the infusion as well, but still there is an ongoing loss. So you can also try tranexamic acid before giving maybe carboprost. So yeah, so that could be next step. So these are again the same things. The routes and the doses are mentioned here, and we have discussed most of the things already. And we know that the most important things to remember is that misoprostol can be used in any settings, and it doesn't need a special storing requirements. And carboprost shouldn't be given to women who are asthmatic, and ergometrin should not be given to women who have high blood pressure, either pre-existing, pregnancy-induced, or whatever, but it's a contraindication. This is a very useful algorithm for the management of PPH. So in case of PPH, we have to secure hemostasis. So if we remember this, that is, we have to ask for help as soon as we identify that the woman is bleeding continuously, or it's beyond the threshold of 500 mils. Ask for help. And then another thing that is very important is to assess, resuscitate, manage the woman at the same time. We can't just take a history and then go ahead with the management. So we have to make sure that the woman is okay. Assessment is started along with the resuscitation. So in terms of assessment, you will quickly ask about the history and what uterotonics she had before, and any risk factors in her history, any blood thinning medication she's on, any other medication which could have interactions with the medicines. For example, if she's a known asthmatic, then we will avoid carboprost in her case. So things like that, but it should be a very quick assessment, and also resuscitation should start at the same time, which we will discuss in a few minutes as well. But basically, resuscitate the woman as we resuscitate any a bleeding person. 2 wide bore IV cannulas, take some bloods for full blood count, group and save or cross match, and coagulation profile, kidney functions, liver functions, and also start replacing the fluid, use some crystalloids initially. Yeah, so we will discuss that in detail later on. And then establish the etiology. As we discussed the 4 T's, so we have to see which T is that at that stage. The commonest cause of postpartum hemorrhage is tone, uterine tone, which is if the uterus is relaxed, then it's a very important cause of postpartum hemorrhage. But we also have to establish the other things. Is it a bleeding tear, which needs to be sutured very quickly? Okay, so these are the other things. And also, if there is any pre-existing medical disorder, or if there is any medical condition which is related to pregnancy, such as preeclampsia, which is leading to some clotting derangement or thrombocytopenia. So these are the things that have to be established so that they can be managed accordingly, because the management of each of these is different. So it's important to establish the etiology and then massage the uterus. We will watch a video shortly, and then it will be much more clear. A very relaxed uterus can respond very nicely to uterine massage or bimanual compression. So that's the next step. And then oxytocin administration. Obviously, one person will not be doing all these things. That's why it's very important to ask for help. So basically, this management is a teamwork. So one person will be doing this. Other person will be passing IV cannulas, start giving her fluids, and give these oxytocics or uterotonics, and shift to operation theater. It depends upon the amount of blood loss, but our threshold for transferring the woman to the operation theater should be quite low, because if the bleeding is ongoing and she starts to deteriorate, even if we don't need to suture her or don't need to go ahead with any kind of surgery, but operation theater would be a better place for her to be in for resuscitation purposes as well. And in case we have to proceed ahead to surgery, if the medical management fails, then that's a better place as compared to the delivery room. And then, as we discussed, that the tissue and the trauma to be excluded, and proceed to tamponade. So tamponade is a good way of management of postpartum hemorrhage. So sometimes a Beckery balloon or a balloon in different places, it could have different names, and even at some places a pack is placed inside the uterus, just like when we have got a wound, a superficial wound, we press it with some gauze, or we give pressure to stop bleeding. So similar to the same principle works here as well. That is, the balloon goes inside the uterus, and basically it's just like a Foley catheter, but the balloon is a different shape when it is collapsed, and then we fill it with fluid. Once it's inside the uterus, it gives some pressure there. It is left there for some hours, and we observe the woman for any ongoing bleeding. So that's a very useful way of controlling hemorrhage again. And then applying compression sutures. So compression sutures are basically a B-lin suture is the commonest suture which is used to control hemorrhage. So basically, these are the surgical techniques. So it compresses the uterus, it holds the uterus and compresses it very nicely. So that's also an effective way in case the medical management fails. So that could be the next step. And then even if that is not successful, then going ahead to the pelvic devascularization, ligating the internal iliac artery, uterine artery, and moving on to hysterectomy would be the last resort. Okay, and in between, if facilities permit, then involvement of the interventional radiologists to do some embolization of the blood vessels to help stop the bleeding. So that could also be life-saving. So we've discussed these T's in the start of the presentation, and as I have discussed before as well, that the commonest cause of the primary PPH is uterine atony, but we also have to exclude the retained products of conception. For example, even if a woman who has got a primary PPH and we try to stop bleeding, but it's still an ongoing bleeding, and the placental tissue, a little bit of placental tissue or some membranes or a placental cotyledon is there, then she wouldn't stop bleeding unless that is removed. So we always have to think about other things as well. So yeah, so that's important, that in addition to the uterine atony, we have to remember other T's. And then it's vaginal cervical lacerations or hematoma. So it's important to examine the woman in good light, with good assistance in the operation theater when she's relaxed, so that we can deal with these things. And then ruptured uterus. That's also an important cause, although not very common, but that's also important to remember. And then broad ligament hematomas, which can also lead to deterioration. Sometimes it's very difficult to identify these things, but it's important to keep these things in mind. And then extragenital bleeding, for example, subcapsular liver rupture, which can happen in case of preeclampsia. So in the management of PPH, basically we have to remember that we have to do a lot of things simultaneously, communicate with the team members, resuscitate the woman at the same time, monitoring should be done at the same time, investigations should be sent urgently, and arresting the bleeding, which is basically our priority and primary aim. But we have to make sure that we do everything at the same time, and then documentation, and then debriefing the woman, which we will discuss in detail in just a few minutes. So communication with the team members is very, very important, because we can't manage a bleeding woman in isolation. So if, for example, let's just imagine that a woman is in room and a midwife is there who is looking after her. So midwife should inform the senior midwife or the labor ward coordinator or the lead midwife, whatever the system is. So she would inform one of the other team members, and then they can inform the attending on-call doctor and the anesthetist and the operation theater team. And it's also important to involve and alert the obstetric consultant and ask them to come for help as well if the bleeding doesn't stop and once it reaches the threshold of major obstetric hemorrhage. And it's very important to inform the laboratory and the hematologist and the blood bank of the situation, so that the blood products are available readily, because in case of PPH, we can't lose time, because if we delay even by a few minutes, the woman may lose either her life or may lose her vital organs. So that's very important. And porters are to be alerted. So all the team members are important, not just the doctors, not just the midwives. Communication is very important, and communication should be very clear. And then, as we discussed, that arresting the bleeding is basically our primary aim. So bimanual uterine compression, one hand in the vagina, one hand on the tummy of the patient, and pressing it firmly, pressing the uterus firmly in between your hands, or doing a bimanual massage. And it's also important to ensure that the bladder is empty, because the full bladder can lead to an atonic uterus as well. And then, as we discussed these uterotonics before as well, we will move ahead to the uterotonics based on what she had before. So basically, this is basically the repetition of what we've discussed. But the important thing is to start arresting the bleeding as soon as it is recognized, and we have to be very quick in our response. I think we have discussed most of these things, so I will just skip this bit and also this one. And then with regards to the resuscitation, the same principles of resuscitation for any acutely ill or acutely bleeding patient. Follow the ABC protocol, assess the airway and breathing. A high concentration oxygen, 10 to 15 liters per minute, should be started via face mask, and it should be started regardless of the maternal oxygen concentration. So it's not important to measure her oxygen saturation at the same time. We have to remember that we have to be very quick in our action, and we don't have to waste time in anything. So we have to follow the important steps. And then to evaluate circulation, and it's important to establish 2 IV lines with wide bore cannulas, 14 or 16 gauge cannulas, and blood samples should be taken and sent for full pet count, coagulation screen, urea electrolytes, cross-match 4 units at least, and basic measures for the minor PPH. This is basically, all of this is based on the MRCOG guidelines for postpartum hemorrhage. IV access and commence crystallite infusion, and measure blood pressure and pulse every 15 minutes. So as we have seen here in this, sorry, just want to go back to one of my slides. So here we have seen that this is basically a teamwork. Okay, so when we will be doing this management of PPH. So one person has to do one thing, and so we have to call for help. So it's very important to clearly communicate and clearly delegate the tasks as well. So monitoring of the patient is also quite frequent, because on one end, we are trying to arrest the bleeding and also giving her doing the resuscitation, but also seeing the response of the resuscitation is important. And then the protocol for the major hemorrhage, when the blood loss is more than 1,000 mils and or there is a continuous bleeding, then again ABC, oxygen, and then wide bore cannulas to flat position. It's important to keep the woman warm and transfuse blood as soon as possible, because there is no replacement to blood. If she's losing blood, she needs blood. But it depends upon the blood loss, and also depends upon her response to the oxytocics or the uterotonics that we are giving, and also her baseline hemoglobin, and also her BMI. So lots of things to think about before giving her blood. But whenever needed, we should think about blood transfusion, because there is no replacement to blood, and crystalloids are not a replacement to the oxygen carrying capacity of the blood. And whenever we are giving them any fluids, ideally they should be warmed fluids. Okay, so there is no need to use the special blood filters because it's just a waste of time. So we have to save time in this situation. And as I've told you before as well, that's the crystalloids. We can start crystalloids as soon as possible. Colloids can also be started to maintain her blood pressure. And then as soon as the blood is available, if cross-mat blood is available, well and good. If it's not available, then O negative blood can be given. And then 4 units of FFPs for every 6 units of red blood cells. And also we have to see the results of the investigations that we have sent. That is, if the PT and or the APTT is more than 1.5 times normal, then she should also need FFPs earlier than 6 units of red blood cells. And then platelet concentrates if the platelet count is less than 50, and then cryoprecipitate. So everything is based on the woman's lab investigations. But for this, we have to involve the hematologist and the blood bank in the management. So it's not a one-man's job. So we don't need to remember everything, but we have to be mindful that these are the steps that we have to take, and we have to communicate with the team clearly to manage postpartum hemorrhage in a better way and to save the woman's life. So basically, the therapeutic goals of management are to maintain the hemoglobin more than 8, platelet count more than 75, prothrombin less than 1.5, and also APTT and fibrinogen should be more than 1. So these are basically the guidelines, but it all has to be tailored according to the women's situation, and again, communication with the team members. So I think these will be this detail will be a lot for you. So, but we have to remember that these are the further management options. That is, in addition to the blood, in addition to the FFPs and the platelets, the next things are the cryoprecipitates. And then we've also got the recombinant factor 7A therapy. But for that, it's important to remember that the fibrinogen level should be more than 1 grams per liter, and the platelets should be more than 20 before it's given. So these 2 things have to be treated before we move ahead to this step. But again, this is a complex situation, so we have to discuss with other colleagues, especially the hematologist, before starting them on this kind of treatment. When the blood loss reaches about 4.5 liters and large volumes of the replacement fluids have been given, there will be clotting defects, and the blood components should be given, as we've discussed. And up to 1 liter of the fresh frozen plasma and 10 units of the cryoprecipitates may be given empirically in the face of heavy bleeding while awaiting for the results of the coagulation studies. So we don't have to wait for the results of the studies to be back all the time, but it can be a clinical decision. So it's important to bear these things in mind. A very important aspect of management of postpartum hemorrhage, especially in obstetrics, I'm sure that this is used in other specialties as well, but especially in obstetrics, cell salvage is very important. The blood shed during an operation is collected and filtered and washed to produce autologous red blood cells. So the blood from the patient's own body goes to a special machine, and then it goes back into her system. So the blood is aspirated from the surgical field using a catheter, And then the filtered blood is washed and resuspended in saline for transfusion during or after the operation. And then the leukocyte depleted filter is nearly always used to in this process to reduce the amount of amniotic fluid contamination in transfused blood levels, blood to levels approaching those found in the maternal bloods, so that it's as close to the maternal blood as possible. But cell salvage does not remove the fetal red blood cells or fetal blood cells, basically. Therefore, adequate NTD should be given to the rhesus negative women. So we have to do a clay horse test 1 hour after the procedure to make sure that as a result of this cell salvage, she does not develop the problems later in her pregnancies. So this is basically the equipment. That is the blood from the surgical site is sucked, and that goes into this equipment, and then it goes back into the patient's body. So that's quite useful. And then comes the role of the interventional radiology that, as we discussed, then there are certain steps: medical management, going ahead with the balloon tamponade, and the brace sutures or the compression sutures. And then there is a definite role of the interventional radiology, and especially in the cases which are known to be at risk of postpartum hemorrhage, such as placenta previa or complicated cesarean sections. So we can speak to the interventional radiology beforehand, before planning the surgery as well, so that, you know, everything is in place before we take the patient to theater. And it helps in reducing the risk of blood transfusion, hysterectomy, intensive care admission, and therefore decreases the maternal morbidity and mortality. And if in the unit we are working in, there is no facility of interventional radiology, then with proper planning, we can refer the women to a unit where there is a facility of interventional radiology. Documentation is a very, very important aspect of clinical governance. So it's very important to document very clearly who was the staff in attendance, what was the sequence of events, timing of administration of different medicines, and what were the timings of the different steps that we took, and then the timing of surgical intervention, and then an assessment of the condition of the women throughout. You know, what was, as I've mentioned before, we will be checking her pulse and blood pressure every 15 minutes. So yeah, so these things are important to document, and the timing of the fluid and the blood products given, how much blood was given. And yeah, so it's very important, and it's important for not only the management at that stage, but for her future pregnancies as well. It will be very useful for the other team members to know later on what did she receive. And debriefing the patient, because that could be a very traumatic experience for the woman and her family, and also the birth attendants. So debriefing the woman as well as the team members later on after the event, because sometimes most of the time, the people who are looking, even the medical professionals who are looking after women in difficult situations, they can also be traumatized by these events. So it's very important to always discuss and debrief at the earliest opportunity, because it's important to do it as quickly as possible so that we don't forget the important bits. So just to summarize, most cases of PPH occur within 24 hours after delivery, and they don't have any identifiable risk factors, although we can anticipate it in many women, but not in 100% of the women. In 70 to 90% of the cases, PPH is due to uterine atony. Active management of third stage of labor can prevent 60% of the cases of uterine atony. Oxytocin reduces the risk of PPH by about 60%, need of therapeutic oxytocin and the need for therapeutic oxytocin by 50%. So active management is very, very useful if women agrees. And then communication, resuscitation, monitoring, investigation, and arresting the bleeding is important and should go at the same time. And most of the time, the medical management is helpful, and using oxytocin and prostaglandin analogs. Two types of prostaglandin analogs we discussed, misoprostol or carboprost. So based on the clinical situation and the facilities, yeah, so any of these can be used. And then intrauterine balloon tamponade is the most appropriate first-line surgical, and it's less invasive than others. You don't even have to go ahead with the surgery, like a proper surgery. Like do a laparotomy. So this is the first line surgical intervention, and that's helpful in most of the women. And then hemostatic suture techniques are effective in controlling severe PPH and reducing the need for hysterectomy. And then is the stepwise devascularization, selective arterial embolization by the interventional radiology people. That is also a useful way, and it has reported to be helpful in 71 to 95% of the women. And hysterectomy should be considered sooner than later, because during PPH, the important thing is to save the life of the woman rather than just looking ahead for the fertility. Although that's also important, but the life is important more than anything else. And after the initial management, continuing care is important. Continuing observations when stable in HDU, and she can be transferred to ITU if required. Hemoglobin coagulation studies should be checked afterwards as well to make sure that everything is within the normal range and she doesn't need any more treatment for that. Thromboprophylaxis is very important for pregnant. It's important for everyone, but for pregnant women especially, because if the coagulation requirements in pregnancy, and especially after delivery, once bleeding is arrested, it's important to start her on low molecular weight heparin. But before that, there are other things like TET stockings, compression devices such as floatrons. So it's important to remember thromboprophylaxis and start the therapeutic thromboprophylaxis whenever possible. Sorry, pharmacological thromboprophylaxis whenever suitable, and screening for coagulopathies if there are other indicators, and screening also for Sheehan syndrome. So sometimes women who bleed very heavily, they because of the loss of massive amount of blood, there could be necrosis of the pituitary gland that can lead to hormonal imbalance, and then screening for the Sheehan, that's called Sheehan syndrome. So that may also be required later on. So as we discussed, resort to hysterectomy sooner than later, and a second consultant clinician should be involved in the decision for hysterectomy. So always call for help whenever there is a difficult situation. So we'll just skip these SBAs, and because you will be having a quiz anyways, so I'm just going to skip this these SBAs. Thank you very much, but I would like to share with you a video as well, just in a minute.
And remember, in the new share, you at the bottom left, there's a share sound.
Can you guys see it?
Yes.
Okay, I'll play from the start. And you can also hear, right?
Yes.
Okay, perfect.
Massive obstetric hemorrhage is a leading cause of maternal death worldwide. It is therefore critical that PPH is recognised and managed by a multi-professional team working together effectively.
Prompt training provides a framework for management of PPH based on national guidance and evidence. We include algorithms that help to make management decisions straightforward for all members of the multi-professional team.
Classroom teaching can provide a forum to discuss key learning points such as accurate measurement of blood loss, underestimation of which can lead to delays in administration of blood products, particularly in women of low BMI.
Scenarios are used to reinforce these learning points in a clinical setting. The emergency is clearly stated and senior members of the multi-professional team are involved early on.
Nice deep steady breaths for me. Well done, Kathy. Hi, this is Kathy. She's a primate. She had a normal delivery about half an hour ago.
Okay.
Following that, we've had a placenta. She's having a PPH. She's got
Okay.
a tonic uterus.
Great. Shall we get the PPH box, please?
Okay.
Kathy, hi, I'm Chris from the obstetricians. Can I send a feel of your tummy?
Maternal observations should be documented on a maternal early warning chart, which should help to alert the team members to the severity of the problem. An algorithm can be used to focus on stopping the bleeding and making a full assessment and plan.
You put another line in, and Lisa put a drip up on this side.
If I take some bloods for cross-match.
If you could take some, would that be absolutely perfect?
If blood loss is significant and ongoing, early transfer to theatre should be considered with a clearly vocalised plan for transfer.
Closed-loop communication should be used to delegate instructions to a named member of the team, ensuring that they acknowledge the request.
Neil, I think if we go to theatre, if we can get some blood from blood bank, Sue, if you...
It can be very useful for the team leader to stand back at the end of the bed, ensuring a helicopter view. The management should be clearly documented on a pro forma. Debriefing can be used to focus on certain elements of the drill, including clinical skills and communication.
Fluid resuscitation and administration of blood products are key elements in the management of any major hemorrhage.
As you've seen from this scenario, the key learning points include a team-based approach and appropriate treatment.
If you'd like to learn more about how prompt training can improve care on your labour ward, or to sign up for our courses, please visit www.promptmaternity.org or email us on info@promptmaternity.org.
Yeah, so basically that is it. Anyone has got any questions?
Thank you very much for your mentorship and teaching, Dr. Kashif. We'll now begin our Q&A session. My name is Amna and I'm an incoming student at the University of Maryland. So to start off our Q&A, our first question is, what are a few factors that determine high-risk pregnancy?
So it depends upon the woman's medical history and also her obstetric history. So for example, a woman who has got so basically it's everything. So starting from the woman's demographic features, for example, age and her BMI, and then going ahead to her medical history. For example, if a woman is a diabetic, hypertensive, asthmatic, any medical disorder can make a woman high risk. And then her obstetric history. For example, she had a previous cesarean section, or she had multiple pregnancies previously, multiparity. Yeah, so basically it's based on a lot of factors, not just on one. Yeah.
Thank you. Our next question is, what are some common factors that can impact regular menstrual cycles in women's health?
Sorry, I didn't get it completely.
What are some common factors that can impact regular menstrual cycles in women's health?
Yes. So again, women's age, her BMI, and then certain medical conditions. And then since there are certain hormonal issues, but that comes afterwards. If a woman has got an irregular menstrual cycle or any menstrual problem, we have to see what is the regularity of the menstrual cycle. How heavy are the periods, or the periods are prolonged and heavy and there is no pattern to the menstrual cycle basically. So it could be hormonal, and it could be also related to certain other things like any abnormality with the uterus, fibroid uterus, and then is there any problem with the cervix? How are her cervical smears? Yeah, so it could be related to her hormonal cycle, any problem with the anatomy of the uterus, and also about we shouldn't forget the cervix as well. Yeah.
Thank you. Our next question is, what inspired you to go into the field of OBGYN?
I can't exactly tell what was that, but over the period of so many years, what I have learned is that I really like working with women, and women in the sense that pregnant women, and especially when pregnant women come to us, they definitely everybody deserves good health care, but that's a very sensitive situation because they are going through the physical changes, hormonal changes, and then they go through basically a big change in their life. They have to look after themselves and their child. So they need a tender loving care. So I wanted to help women from that aspect as well, that not only physically, we should always remember the psychological aspect of medicine. Yes, that's important. And also in gynecology, women come with various problems. There is a very wide range, age range, and then based on that age range, women have got different needs, different problems. On one end of the spectrum are young girls coming with, adolescent menorrhagia or, these kind of requirements. And then are the menopausal women whose needs are totally different. Yeah, so it's very nice. And actually, obstetrics and gynecology is a very nice combination of surgery and medicine. Yeah, so that's why I think that was basically the reason that I have always liked working in this field.
Thank you, Dr. Kashif. Our next question is, what are the most challenging aspects of working in OB/GYN?
Yeah, then again, you are dealing with not only the woman, but in obstetrics especially, you are not only working with the woman, it's a whole family basically. And you are dealing as a patient, you are dealing with two patients basically, the woman and her child. And if we look again from the psychological aspect as well, it's the family which is involved. So that's a challenging aspect. But then again, if well managed or they are happy, not always a well managed patient is happy, but anyways, that is an important aspect. So then all is well that ends well, but that could be challenging at times as well. And then women at the other end, like the women who are postmenopausal, they are having lots of medical issues sometimes. So these are the challenges. Yeah.
Thank you. And another question we have was, are there any unique cases from your career that you'd like to share with us?
Yeah, so there are a few actually, but what I remember at the moment, I can tell you about two actually. So there was a woman I did a cesarean section on, and she actually had a cesarean section previously, and on ultrasound scan throughout pregnancy, she was thought to have an ovarian cyst. So that's why she also opted for, she didn't want to have a trial of vaginal delivery, but then she wanted to have a cesarean section and also removal of the cyst. So I did a cesarean section, and surprisingly, that was not an ovarian cyst. That was a uterine cyst, which is very, very rare. It's called a Mullerian cyst in the uterus. And that was a cyst at the back of the uterus, just like an ovarian cyst, with clear fluid, but very different. This was not what we were expecting. Yeah, so that was very nice and different. And I have actually written a case report on that as well, and that will be published soon. And there was another one that I can think of at the moment. A lady came in early pregnancy with an ovarian cyst. She had a laparoscopic surgery, and it turned out to be an ovarian cancer, and she was pregnant at that stage. Yeah, so that was also interesting. There are many interesting cases that we come across, but yeah, these are just two examples.
Got it. Thank you. And for our last two questions, can you walk us through a day in your life, as in what you do on a day-to-day basis?
I mean, apart from the weekend, it's quite busy, like just a routine, 8 o'clock to the hospital and 5 o'clock off. Some days are long days, but working at the hospital in different shifts, like in obstetrics and gynecology, on rotational basis, and then I spend time after coming home with my family, with my children, and then weekends I prefer to spend with my children. Yeah.
Yeah, and kind of branching off of that, for our last question is, how do you manage your work-life balance?
So work for everyone is stressful. So in order to relieve the stress, I try to spend time with my children and then sometimes go out for a walk. And yeah, because like my plan now is to, after this session, I will be going out with my little one. Yeah. So these are basically, this is basically how we have to manage ourselves and the stresses and the work-life balance. Yeah. And don't stress yourself with work. There should be some time off, and we should try to choose jobs which are not too demanding so that we can spend some time with ourselves and our family.
Thank you so much, Dr. Kashif. Those are all the questions we have for today.
Thank you very much. Thank you so much for inviting me for today's session. And it's always a pleasure. And good luck, everyone, with your careers in future.
Thank you very much, Dr. Kashif. We really appreciate you taking time to answer all of our questions and taking time out of your day to mentor us.
No worries. Thank you so much.
I'd love everyone to please give a warm thank you to Dr. Kashif in the chat box for this incredibly informative session. Thank you.
Thank you.
Now we're going to conduct our closing session with our quiz and our future session dates. The link to the quiz for this session is now live. You will need a 70% or higher to pass and receive certification. Now on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, May 21st at 10 a.m. Eastern Standard Time, with our physician mentoring us in internal medicine. Thank you so much to everyone for attending today's session. We hope to see you in upcoming sessions. This concludes this week's shadowing session. Thank you.